Welcome back, everybody, to part 2 of our massive 150-part IPDRG masterclass right here on Decode Healthcare. I'm Harshal, and I am absolutely thrilled to be your guide as we continue diving deep into the world of inpatient medical coding. Now, in part 1, we kind of set the foundation, right? We talked about the inpatient prospective payment system, we broke down how that DRG payment formula actually works, and we explored how accurate coding literally impacts the entire hospital revenue cycle. But today we're putting on our detective hats and jumping straight into the medical record itself.
But real quick, before we officially kick off today's guided tour, I've got to remind you, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Honestly, your support is what helps us keep this incredible resource completely free for everyone.
All right, so here is our roadmap for today. We're going to cover 1, intro and overview, 2, the face sheet, 3, discharge summary and H&P, 4, daily progress notes, 5, non-codable documents, and 6, a summary and teaser for next time. Let's get to it.
Starting right off with Section 1, Intro and Overview, the Inpatient Medical Record.
Okay, so if you take literally nothing else away from today's lesson, I want you to remember this absolutely crucial core rule. Inpatient coders must abstract details across the entire medical record. You just can't rely on a single document or, one convenient summary title. The patient's clinical journey is like a giant puzzle, and as clinical coding experts, it's our job to synthesize all that information from day 1 all the way to the day of discharge to get the correct DRG.
Moving right along to Section 2, the face sheet, high-level summaries.
So this standard inpatient face sheet is almost always the very first thing you're going to see when you open up a chart. Now, sure, it contains a lot of administrative data, but more importantly for us, it holds those high-level clinical summaries. You're going to want to evaluate the primary fields here, like the admitting diagnosis, the principal diagnosis, secondary diagnosis, and of course any principal or secondary procedures. But, linking back to our core rule, we don't just take this sheet at face value, right? We use it as our starting hypothesis. And this brings us to a major tripping point for a lot of students. You've got to clearly delineate between the admitting diagnosis and the principal diagnosis. The admitting diagnosis is usually captured right there at registration, or maybe down in the ED. It's basically the primary reason the patient walked through the doors in the first place. Think severe chest pain or fever of undetermined origin. But the principal diagnosis, that's the final diagnosis established after study.
Which brings us to the exact official definition you absolutely need to memorize. The principal diagnosis is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. So why does this matter so much? Because the principal diagnosis always determines the DRG and the base reimbursement for the hospital. If a patient is admitted for chest pain, but after a few days of testing it turns out they had an acute myocardial infarction, well, the MI is your principal diagnosis. The underlying condition is always sequenced first.
Let's dive into Section 3, Discharge Summary and H&P, the bookends of care.
Now here we have a classic discharge summary. Guys, this document is absolute gold for coders. It summarizes the entire hospital course, confirms the final diagnoses, outlines the treatment outcomes, and details the discharge disposition. If the face sheet gave us our quick summary, the discharge summary gives us the concrete clinical justification. Your coded diagnoses have to match the clinical picture painted right here in this document to ensure billing compliance and, of course, avoid those pesky audit risks.
Then, on the complete opposite end of the timeline, we have the H&P, the history and physical, done at the very beginning of the admission. This outlines the reason for admission and the initial, often tentative, diagnoses. It gives you the full context of the patient's condition on day 1. But remember, the diagnoses documented here are often just preliminary guesses. We don't usually code tentative admitting diagnoses from the H&P as our final discharge diagnoses, well, unless they're actually confirmed later in the chart.
When you actually break down the H&P, you're looking for specific components. You've got the chief complaint and the history of present illness, or HPI. But you really want to pay special attention to the past medical, social, and family history sections. While you skip over those tentative admitting guesses we just talked about, you definitely want to capture codes for chronic active conditions, personal history of certain diseases, or relevant family history. Those can actually impact the severity of illness and sometimes even bump up the DRG itself.
All right, on to Section 4, Daily Progress Notes, the granular clues.
So, a patient's chart evolves every single day, and that continuity of care is documented in 3 main steps.
You have the admitting note, the daily follow-up notes, and finally the discharge note. Reading these chronologically lets you track the ongoing management of all the patient's conditions. This is where you see the real-time response to treatments, and honestly where brand new diagnoses might just suddenly appear mid-stay.
In a typical progress note, like this, you're going to find the critical specificity that those broader summaries might just miss entirely. Does the patient have a fracture? Well, this note will tell you the exact bone, the laterality, whether it's left or right, and if it's an open or closed fracture. Does the patient have heart failure? The progress note will clarify if it's acute on chronic systolic heart failure. That exact level of detail is precisely what you need to assign the most accurate, highest-paying DRG supported by the clinical evidence.
Now here's a great question to test your detective skills. What happens when a procedure is performed right there at the patient's bedside and there's no formal operative report? Think about things like a bedside percutaneous biopsy, or maybe a central line placement, or a Foley catheter insertion. You have to comb through these daily progress notes to spot and capture those procedures. If you're only looking at the surgical section of the chart, you're going to miss these codable events completely.
Let's look at Section 5, Non-codable documents, avoiding the red herrings.
A medical record is absolutely full of administrative noise. Take a consent to admission form, for example. It's generated at registration purely for legal purposes. As a medical coder, you can entirely skip over this document. It contains literally zero diagnostic data that you can use to assign an ICD-10 code.
Here's another great example, the Advance Directive. Now this is a super vital document for patient care, outlining their rights and end-of-life wishes. But again, for the strict purpose of DRG coding, it's a non-codable administrative document. You can just skip it. The exact same goes for graphic charts tracking daily temperatures, patient property reports, and basic nurses' notes that just cover routine daily care.
So, the real crucial takeaway here is why we skip these. They exist for legal protection, nursing workflows, and administrative tracking. They simply do not contain codable diagnostic or procedural data. By filtering all this extra stuff out, you keep your focus strictly on the clinical documentation that actually impacts the DRG, which is going to make you a much faster and much more accurate coder.
And finally, Section 6, Summary and Teaser, preparing for Part 3.
This table beautifully summarizes our golden rules of chart navigation. Your face sheet and discharge summary, high coding relevance. They give you your principal and secondary diagnoses. Your progress notes, also high relevance, because they provide that vital clinical specificity and help you capture bedside procedures. But your consents, directives, and property forms, zero relevance. Just skip them. You now have a really solid, efficient roadmap for navigating any inpatient chart.
But I want to leave you with a thought as we prepare for the next lesson. What happens when the physician's diagnosis in the progress note doesn't match the actual lab results? What if the doctor writes possible pneumonia, but the X-ray is totally clear? In Part 3 of our masterclass, we are going to dive into the tricky world of interpreting ancillary reports, so lab data, radiology, and EKGs, and we'll discuss exactly when you need to query the physician for clarification. You are definitely not going to want to miss it.
And that wraps up Part 2. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Keep practicing your chart navigation, stay curious, and ask yourself, what will you do when the doctor's diagnosis and the lab results completely contradict each other? We'll solve that mystery together in the next explainer. See you then.